We hope that today is a day of hope, and that there's hope in the vision for the future. You know, we often wake up in the morning, and quite often after I flip on the news, I want to pull the covers back over my head because it feels like the world's going to hell in a handbasket. And we hear about all the difficulties, all the tragedies in the world, and they're very true. They're very true, and they're a challenge. But one of the things that really caught me when I first heard Dr. Jamison talk about the Lancet report, Global Health 2035, is that there is hope for the future. And there are things that we can do that don't have to cost a boatload of money to really make a difference. And so what we want to explore today are the meanings and the issues identified in this report, and to think about what we at UCLA can do to make a difference. So it's my pleasure to introduce our first speaker, Dr. Dean Jamison. Dr. Jamison has a long and distinguished career at the World Bank. He was a professor here at UCLA before he moved to the University of Washington. He's an economist, a health economist, who worked on the first World Health Report out of the World Bank, and he co-chaired with Larry Summers the Commission on Investing in the Health, which was published in the Lancet in December 2013 as Global Health 2035, a world converging within a direct generation. Dr. Jamison.
Well, Tom, thanks both for the introduction and for this occasion, which I think is an exciting one. For me personally, it's certainly a pleasure to be back at UCLA. I get here from time to time, but I spent many years here, including directing UCLA's Center for Pacific Rim Studies for some time, and I have a number of my former colleagues here today. It's been great to see. This Global Health 2035 was published by the Lancet, proposed in conversation with Richard Horton, who you'll hear from in a minute, as a 20-year reflection on the World Bank's World Development Report for 1993. But one of the things I note about our title, which I think now is a little bit ahead of its time, listening to Tom and the new center here, we have a world converging within a generation. So I'm pleased that we got that right, Tom, without having to check with you. So, but 20 years ago, the World Bank published this World Development Report, 1993, a topic selected by the then chief economist of the World Bank, Larry Summers, and prepared under his general direction. And 20 years since then is really a long time. 20 years is a long time in global health. And it has been a period of enormous progress on the whole for humankind, despite the kinds of setbacks and problems that we all, I think, along with Tom, see in the newspapers almost every morning. But there's been huge economic progress. This slide is a very simple-minded summary of that economic progress, of a transition from, in pink, the low-income countries and the fraction of the world's population that lived in 1990 in low-income countries to a much tinier fraction living in what the World Bank defines as low-income countries today, and similar transitions from lower middle to upper middle income. So there's been huge economic progress, but probably more dramatic than that has been the general progress in human health, the declining of under 5 mortality rates, of maternal mortality rates, increasing life expectancy in high-income countries by 2 to 2.5 years every decade, and in many of the lower-income countries, but far from all, increasing of life expectancy by 5 years every decade. In addition to the practical progress in human health, there's been an enormous transformation of the global institutions, new institutions like UN AIDS, the Global Alliance Against Vaccines and Immunization, the enormously financially significant global fund against AIDS, tuberculosis, and malaria. All these are institutional creations of the last 20 years. Science has progressed in ways that benefit the health of the poor in enormous ways. And this report provides at its beginning an overview of these tremendous changes in science and institutions, and mostly and most importantly in human health. But then its task is to look to the future. What are the problems really remaining today? And what are some of the policy issues confronting national governments and confronting the global system as we look forward to the next few decades? And so we describe in a fairly standard way, I suppose, three dimensions of health problems. Continued high rates of avertible infectious disease, tuberculosis, AIDS, malaria, child deaths and maternal deaths. Demographic changes. Fertility declines have been remarkable. Those fertility declines lead reasonably directly and predictably to average age increases in populations, and that quite predictably leads to major increases in the incidence of non-communicable disease. And we document those recent trends. We make projections for what those trends will look like over the next few decades. And we talk about the role of medical expenses in creating poverty. And I think as development economists have increasingly studied the causes of poverty in developing countries, the important role of medical expenditures, either high routine expenditures or large sudden expenditures in impoverishing households, pushing them below a poverty line that often creates a downward spiral from which they can't, or from which it's very hard to recover. And a lot of the global discussion now is around universal health coverage, like the discussion in the last few years has been in the United States of extending our financial coverage to ways that start to mirror those European countries. So we looked at those three categories of challenges and what they might mean. And I'm not going to try to go over most of that, but rather to hit two highlights and some of the implications, I think, for the global system. So the first highlight of the report is what we claim to be the feasibility, the technical feasibility, and the financial feasibility of a grand convergence, a grand reconvergence in the health conditions of populations around the world. And this picture shows initially enormous divergence. What the picture shows is under 5 mortality rates estimated by historical demographers, and then more recently for Sweden and for China back to 1750. And the projections back for 10,000 years before 1750 look pretty flat, around 350 or so, with lots of ups and downs. But the 2 points about the picture are that the levels of under 5 mortality and health conditions more generally, I'm using this simply to represent overall health conditions, were both extremely poor for all of human history until the last few centuries, and they varied relatively little in any systematic way over time or across countries. Sure, there were the ups and downs of famines and wars, pestilences, but those were ups and downs that varied over space as well. But there were not any major trends until in some of the then relatively high-income countries, there was this remarkably steady, protracted decline in mortality rates shown in the blue line for Sweden for the period to about the early 2000s. And the red line shows a similar trend over time for China. The dotted line shows divergence, as it the difference between those two rises rapidly as Sweden's mortality rates fall, but then as much later China's mortality rates began to fall also, there is divergence leading to Chinese position that is certainly not as good as Sweden's today, but is not too much worse. The thesis, the main central thesis of our report is that in another 20 years or so, with the right investments and the right policy, but not without those, but with those, the rest of the world, the parts of the world, and large parts of the world are, as you all know, far behind what China is today. That the rest of the world can fundamentally conquer the problems of under 5 mortality, maternal mortality, of AIDS, of tuberculosis, and malaria. It's a strong claim. It's one we spend a lot of time talking to the experts in all the relevant fields about, but it's a claim, as I indicated before, of financial and technical feasibility. It's not assured politically. It's not assured in terms of managerial competence. So one main message, and a very hopeful message as Tom described it, is of the possibility of this grand reconvergence. And the report talks a lot about what that might cost, puts numbers and aspects of it that I will not try to go through here, except to make one point on costs. That we estimate that the costs in low and middle income countries of paying for the introduction of the additional interventions required to achieve this grand convergence would be on the order of 1% of the increase in their GDPs that is expected over the next 2 decades. So that underpins the claim of financial feasibility. A lot of discussion around the technical feasibility, but it's not a speculative discussion around technical feasibility, because a lot of quite low-income countries, China earlier, Rwanda recently, have in fact gone through much of this convergence. So it is feasible. So that's one major point I'd like to talk about. Leave with you. Second major point addresses the issue of the financial vulnerability, the impoverishing character of medical expenses in long institutional environments. And that has led to increased discussion, increased commitment around the world to some variant of universal health coverage, universal financial coverage. And while there's agreement on that, of course, the question of how you're going to pay for it. And given that most countries aren't too close to universal in the sense of all people, almost all of the expenses, for almost all of the interventions that are medically worthwhile, where the medical benefits exceed the medical risks. What pathway toward universal health coverage might make sense? So our commission spent a lot of time discussing pathways, and we came to a few conclusions about, summarized in this picture, a few conclusions about desirable pathways and a few conclusions about undesirable pathways. And let me summarize without making the arguments. First, the two most significant, in our views, wrong ways to go to achieve universal health coverage. One wrong way to go is to rely on private voluntary insurance. The U.S. provides very strong arguments for that, but there are many other examples as well. So the use of private finance, including private mediation of private finance through private insurance, is, we argue, distinctly unpromising way to provide financial protections to whole populations. And the second direction that we feel uncomfortable with is use of public money to insure against the most expensive procedures, what many health economists call the catastrophic expenditures, that those should be dealt with first. We argue, and this picture is a depiction of that argument, that the most cost-effective, often relatively inexpensive interventions should be covered first. And the cube, this is what's called the WHO cube on health finance, reflects the three dimensions that I just discussed of population coverage along the bottom axis, going to the back and to the right, the prepaid axis, what fraction of each procedure on average is covered by the insurance or state provision. And then vertically, what fraction of interventions are covered. So the blue at the bottom reflects the interventions first that are essential for convergence. And then the after that, and the argument is that first, public money should be used to expand coverage to all of the population, to those critical interventions at low or zero cost at the point of use. So the blue covers two dimensions almost fully at the outset, and it does so at the cost of only a limited number of interventions being covered. So a lot of our stress is on what are the trade-offs, and that's where we conclude the trade-off should be struck at the outset. Then as time evolves, as resource constraints ease over time, the main dimension of expansion is through a richer and richer set of interventions to be covered. So those are the two main points that I would like to leave with you. And these points have enormous implications for national policies and for the international system. And they argue for a radical transformation, restructuring of the global role to dealing with global public goods, most prominently to investing in the new research and product development that will give ever better technologies. And we have a long list of things that are promising in the next 10 years, ever better technologies for dealing with the problems of the poor, but also dealing with major cross-border externalities, diseases, drug resistance, pandemic flu that will, with all likelihood, sometime in the next 10, 20 years appear. These are where international resources, rather than in the support of routine health system operations. That will be a big change for donors and an even bigger change for many countries. The message, though, at the end of the day, with right policies, there can be this phenomenal transformation, this continued transformation, almost to completion of the movement toward universal low mortality, and that can be done in a way that slowly but realistically provides financial coverage for entire populations. Thank you.